Welcome to Health Reimagined, the future therapist, where bridging tech and tradition is the discussion topics we're going to have. On today's podcast, we're going to explore cutting edge developments shaping the future of healthcare and physical therapy. So, I'm your host, Dr. Meenal Patel, physical therapist. I have been practicing in the physical therapy space, outpatient ortho space, 15 plus years, and have since transitioned to working with a technology company called SPRY into the digital space here. And I have with me our guest, Alex Bendersky, who is a digital health leader, a great champion of the healthcare digitization space, and also really interested in the value-based care for physical therapy as well. So thank you for joining me today, Alex. Welcome.
Pleasure, and thank you for having me. Looking forward.
Absolutely. We have a lot to unpack. I know there's, a large list of things that we can talk about when it comes to healthcare, physical therapy, digital health, and what it all means. But I thought, what better place to maybe start than actually defining what digital health actually even means in particularly the physical therapy space. So if you can give me some, with your expertise, information on what does it even mean? What is the definition of digital health?
It's a terrific question, and I think definitely labeling ecosystems for what they are and establishing a structure towards that definition is a good first step. So, digital health is an ecosystem where an individual can receive care through the multitude of the spectrum of healthcare options in a digital space, which means they can be triaged, assessed, evaluated, and treated through the digital ecosystem without encountering a traditional medical model. There is a multitude of options, and obviously there is still a poorly defined structure to the digital system. But I think for what it is worth, it is the entire medical clinical encounter occurs in a digital ecosystem without any traditional brick and mortar model.
Got it. So it's not just a fancy term for telemedicine or telehealth, is it? It's more than that.
No, no. So it is not, but I think what you will see is because of still a poor, I guess, low level of acceptance and still poor level of definition. I think digital health can really mean anything, and a lot of companies use it as just a loose jargon term for saying that they have developed a website or they have some digitization, not fully digitized, but they have a digital product. So then now they're participating in digital health. But I do think that there are companies that are truthfully, uniquely digital health first or digital health only. And that is the core, the foundation of their business and the foundation of their healthcare model. And that is what I think the fundamental digital health is.
Yeah, it's interesting because, at some point it should and it will hopefully affect that patient experience as well. So where do you think we're at this point with companies, accepting digital health as part of their processes, and then what is the outcome on the patient side of things? Are we seeing the changes already, or is that yet to come still?
Yeah, so again, I think that is a very good question to cover. I think that there's a very large spectrum of what digital health is represented by these legacy companies, and I think to most they see digital presence as just a nominal fact that needs to be covered. But there is a plethora of digital first and digital only companies that are, I think, making their presence felt, especially in the United States, where a lot of companies are trying to circumvent traditional clinical encounters and create a digital front door or digital first company. So, example being, if you were to experience a musculoskeletal complaint, some companies will steer you towards a digital encounter or digital triage, and then from that point, a decision is made whether you continue on the digital system or you transition to a legacy system. But it is definitely a worthwhile conversation, even in the future, to pick out what it is and how do we actually define each structure and each spectrum for what it is.
Sure. I love that you gave the practical example, right, of a patient seeking musculoskeletal care, and they are now ready to be seen by a provider whether it's the physical therapist or the physician, whoever it might be, and where does it start for them then in that digital first sort of process? Does it start from, being triaged online with a certain set of questions and digital surveys, or does it, also go to the fact of, computer vision and, assessments through movements and things like that that happen prior to them even getting in to see that provider? So what do you think then, Alex, in terms of, is this space only for the tech savvy, or is it doable and, usable for those who are not so tech savvy, or don't really believe in this whole tech side of things when it comes to healthcare?
Yeah, yeah, absolutely. Right. So what is the comfort level and what is the acceptance of technology in the general community? And I think you'll be surprised about how digitized and digitalized our life has become. I think it's 2025, so I think every aspect of our life is digital, and so we tend to put the label of digital system into something that's still future focused. But the truth of the matter is, most of your clinical medical encounters, most of your medical experiences are digitized, with your records, with your checking your tests, or even scheduling your appointments in a traditional model, still done through the digital ecosystem. We really have to see a clinical encounter not as a single episode of care, which I think a lot of us are just more framed to be, but as a continuum of care. And a digital system is a way for us to access and promote accessibility to general public and general population, and it's already happening. I think there was an interesting study that looked into that geriatric population, and traditionally speaking, we think that there's a low acceptance rates of technology in individuals over age 65, right? And they found that there was an 87% acceptance rate of digital ecosystem. So people actually preferred digital system, and so we really, I think, have to welcome it and embrace it, and ultimately structure it in a way that it's not labeled digital, but it's just a system. It's just one of the entry points that promotes accessibility.
Sure. And that promoting accessibility, as you mentioned, being the key factor, right? It getting the patients and the users of that healthcare system to seamlessly interact with the providers, without all the burden of the non-digital system, which, we certainly have that. It's not that it's, the non-digital system is providing us with everything that we need in a very easy way. So obviously, having that digital system to help us increase that efficiency and accessibility and improve, that relationship between patient and provider, obviously makes a huge difference as well. So then let me ask you this as well, Alex. So you were talking about, on the user side of things, or on the patient side of things, that how the digital system would be, helpful for them. But now, as a healthcare provider, as the physical therapist that is on the other side of this, tech, is this going to help with what we talk about, this burnout, that we're experiencing lately in the industry, or that we, saw a huge increase of during COVID and post-COVID times? Is the digital system the answer to improving this burnout?
I think this burnout is definitely a popular term to cover right now, especially in the United States, and especially in 2024, 2025, right? I think we have to go into the deeper structure of why is the burnout present, and part of it is that we have this mismatch, a conflict of availability of care and provision of care. So we have an increased burden of the supply and demand challenge, where legacy practitioners are being challenged to see more patients at a lower reimbursement rate. And yet at the same time, as the analogy goes, like eating from the same pie or building a bigger pie, a digital ecosystem allows you to both build a different pie or just extend the pie you have, because now there are patients that are probably much better suited for receiving care remotely or digitally, asynchronously from a traditional practitioner. That actually frees up a clinician to provide care where it's most needed. And I think it's again going into that supply and demand challenge, allowing clinicians and practitioners to do what they do best, which is taking care of patients that need their care, but being discriminate about the type of care that the patient can best benefit from. And so some patients benefit from being seen asynchronously and being treated through the digital systems. Some patients do really well being taken care of being taken care of in the traditional system, and most likely there's a transition from someone being brought into the system digitally, being triaged digitally because those tools are available and accessibility is available. Then when there's a need, you stratify risk and you provide in-person care when it's needed, but then you offboard that patient back into the digital system. So think of the analogy that always resonates with me is you get on the train and you get off the train when there's a station that you need to get off on. But ultimately, the train allows you to get there. And we're talking about a recovery journey, which is really not a single point of contact, but a transition. So you get on and off the digital train, you get on and off the traditional train whenever it's needed. And if we structure it well, that will definitely help the burnout because again, the clinician will be able to see the patients that they need to see instead of being challenged to see the patients that they don't, just to, unfortunately, meet the economic demands. So.
Sure. Yeah, I think that analogy of the train is a great way of putting the fact that it is a journey through, start to finish for that patient that is going through that musculoskeletal care, for example. And how do we, as the clinicians, as the healthcare providers, help them navigate that journey through all the different stops that can be made. And, essentially those tools that we have, I'm sure you heard the same terms when you were in PT school, the tools that we have in our toolbox, right? So that tool that we have in our toolbox to help them, get through that journey of improving their symptoms or pain or function or whatever it is. And digital tools are just that. They're another set of tools. And why not, as, clinicians, that we utilize that tool to also not only help our patients, but also help us to make sure that we are, in an environment that affords us to be, not burnt out and actually enjoy and stay within the system as we really enjoy doing. So, yeah, I like that analogy of the train. That's a good one that we can keep in mind for sure. I think, talking on this burnout track that we're talking about right now. Do you find, or what is your input on, outside of the number of patients that are now required to be seen for, economic purposes or for financial stability of that clinic, et cetera. Outside of that, have we taken for granted over time that physical therapy has been physical therapy for X amount of time and we haven't necessarily changed with the times in order to help with this catch up of burnout and situations that we're now experiencing? Or in other words, did we remain stagnant for too long and now we're in this area of big change? Or are we just being forced to change now that we see the economic changes that are occurring on reimbursement and things like that?
Yeah, that is an important feature to cover, right? What is the directionality of change, and is it that we are being forced by the pressure and current social ecosystem, or are we just stubborn and we're a rigid practice? And I think it's a little bit of both. I think if you were going to be a time traveler and if you're going to go into a clinic in 1989 and then you come back to 2025, in a traditional sense, you would see very little difference in how physical therapists practice. It's pretty much the same technology. And I'm not talking about that 10% of advanced physical therapy practices that are really well equipped and technologically equipped, nor am I talking about the 10 to 15% of just outliers that have nothing, right? Like they're just bare bone practice. But the traditional, that 60% of practices, they're the same as they were for the last 50 years. And partially it is our fault because we have created only two ways of graduating and improving our practice, where we have a clinical growth, which has a low ceiling, because once you've taken all your CEUs and once you got all your certificates and all your numbers and letters after your name, then you're pretty much it, right? Or we have administrative growth, where the administrative growth, after 3 to 5 years, you're a successful clinician, so then you're giving other responsibilities, but responsibilities are economic and growth-oriented, not really clinically oriented. But there's no third growth potential. There's no innovation. And I think that we are unique as an industry, that physical therapists traditionally are innovators in the clinic. We do creative things to help people improve, but there is no avenue to innovate technologically. We don't have any opportunity to improve and bring other methods, other tools in our toolbox in a clinic from the outside. So we stagnate. And because of that directionality, because of the stagnation, that creates redundancy and boredom and languishing. And once we languish, like after 5 to 7 years, we start looking at other opportunities. And that is one of the reasons why you have 10% attrition of the workforce. That's why you have such a big dissatisfaction with care, even though like we're still a very happy profession. We don't have that opportunity for growth that you would see in other medical professions where you can always innovate and improve. So I think it is both. It is us not doing our job to innovate, but it is also that social structure and social pressure that doesn't allow us to innovate. So
Sure. So I guess, as I'm thinking about this, as you spoke about, that middle 50% that, like, as you mentioned, has likely been practicing for the past 50 years in the same sort of traditional ways. In this age, like you said, where everything that we do, our phones, our video chats, all our lives are certainly mixed with this technology more than we maybe want to admit. What can those kinds of practices, let's say tomorrow, today, if they're listening to our podcast, start to think about implementing within their very traditional framework currently, to move them along the spectrum towards that more digital health toolbox now? Maybe they don't have all of the resources, the funds, the whatever it may be, but are there places where the majority of these practices that are very traditional at the moment, that they can start thinking about how to incorporate these new tools into their system?
I think that the first step is we have to educate the educator. So we have to provide exposure to these digital tools at the lowest threshold, at the lowest level of comfort, which is it's already there. It's not something that's not present, as you were mentioning, it's omnipresent in your life. You use technology for pretty much every aspect of your living. If you live in a like 2025, pretty much anywhere in the world, right? But getting somebody comfortable with technology has to come through a realization that where you are now, the status quo is not good enough. And potentially, just because you have habituated to work in the way you do, doesn't mean that there's no other better ways to work through efficiency. And that's what the digital ecosystem does, is it improves your efficiency. Like there is a human factor and then there's a technological factor. And we have to be humble enough to understand that humans are good at doing human things. Technology is good at doing technology things, but technology is the extension of humanity. And so, again, using the analogies, I can choose to walk 10 miles, and that's satisfactory for leisure. But if I need to get to the store, I'm going to get into my car and go to the store because it's a natural extension of my ability. I can get to the store faster, do my deed, come back home, and I'm happy, and it took me 20 minutes. With the same burden, with the same constraint in a clinic, you can choose to do what you have been doing for the last 50 years, and you potentially get there. But those are all constraints. Or you can choose to leverage technology, and all of a sudden, that same task that used to take you 30 minutes takes you 3 minutes. The same, like, not to use like the low value, like rudimentary things like documentation that used to take you 7 minutes, 10 minutes after the traditional note, now it takes you 30 seconds, right? It's not a cheat code. It's actually an extension of your natural ability. You then liberate your time, you democratize your time to do something that you do best as a human being, which is consulting, educating, taking care of people, using your clinical skill set to improve. But then this democratization has to occur through the clinician, through the practitioner, accepting technology for what it is. It's an extension of your natural ability. So I hope there's going to be a higher rate of this in the future.
Yeah, I think that's really key, as you mentioned, that word of, educating that user on what it is that it's going to do for them. It's not just employing it within the clinic, but it's also what is it that's going to do for you? What is it going to afford you? Where is your output in that going to lead to? So that time factor, as you mentioned, with something as rudimentary as documentation, right? So for the most part, most of these traditional systems are obviously using an EMR, using some kind of system to be able to get their documentation or scheduling or billing or whatever the case may be through some kind of digital technology based system, and using that to help them again be efficient, be productive in a sense where they can then use that extra time that they now have towards that clinical factor, or that patient, or that improving the systems within their own clinic in other ways, etc. I think a lot of times I'm guilty of this as well. I practiced for 15 plus years, and that system that I used within the clinic became sort of this extra burden, without necessarily the deep understanding of, okay, it's not just an extra burden, it is a tool to get me to where I need to for my daily practice with my patients or with myself even, right? I know that there's this, big, oh, it'll save you time and you'll get to, go home and spend time with your family, or not take your documentation home, etc., which is all great, right? It's all certainly things that we strive to have, but it's beyond that, isn't it? It's beyond just those few things. If I understand what you're saying correctly, that it's this understanding of where is it that I can take me beyond just these small aspects that I think it should help me with, but it's probably a little bit more than that, right?
I think like just the basic problem of energy expenditure, right? The energy is not a limitless resource, and we have like our fuel tank is full in the morning and then it's empty in the evening, and the reason why it's empty is like every encounter, every task takes a little bit of energy out. So a good example of reducing the burden from these energy expenditure events that don't need to use up your fuel. I think of the Mark Zuckerberg and Steve Jobs are notorious for wearing the same article of clothing, because they didn't want that burden of choice. They thought that like it didn't matter what they were going to wear in the morning, as long as they could achieve their like higher value tasks. For a clinician, it's the same. It's not just having more time with your kids in the evening, which is great. I mean, obviously that's what, but even in a clinic, you always have this sub-threshold awareness that you have to do this and you have to do this, and it does not add value to your clinical encounter. It doesn't add value to you as a human, right? Because you are like your fuel tank is running low and it's only 4 p.m. and you still have all the other things to do. So this democratization of energy comes through addition of technology, like add technology to help you do what you do, so that by the end of the evening, you still have a quarter of a tank left. You can do things that you like doing. So I think it's that. It's not just a single task. It's just everything. We have to think of ourselves as energy consuming beings. And so we want to preserve this energy for things that matter to us, instead of expending this energy for things that don't matter, but that require energy.
Yeah, absolutely. All right, so Alex, I wanted to talk a little bit more now, since we've been on this, discussion of digital health and sort of technology. Uh, if we can go towards more the discussion of AI and this other buzzword of AI and robotics and how that is coming into our physical therapy space specific, right? We hear about these buzzwords often. Does anybody specifically know what these buzzwords mean? I'm not sure, but it's worth having that discussion on what it could mean for us in physical therapy space. So what is, the general overview, do you think, of AI and robotics within physical therapy at the moment for us?
Yes. So I think AI in general, right? It's kind of like a throwaway term that is overgeneralized into any form of language models that have been integrated into our existence. But in physical therapy, the biggest utilization of AI currently has been as an ambient sound reception, and to help us reduce the burden of note taking in a clinic. And I think that is probably where you see the highest success of penetration on a traditional sense. If you look into the AI capacity to help us provide care, there's just an exponentially larger capacity to extend our natural clinical abilities. Think of AI as walking around with your 100-tome dictionary wherever you go, and every time you encounter a patient, the dictionary gives you a suggestion based on the best available evidence that, again, reduces the burden of you needing to reference everything yourself, but gives you a suggestion. So there was actually an interesting study, and I'm sure you've seen these more recently that have been popularized, that AI outperformed physicians in some form of clinical diagnoses. And what they found that there was three independent curves. Like AI did better than a physician, but a physician with AI did better than AI alone. So that, like, we would call it a human in the middle. So a human driving AI, because AI is nothing more than again, a trained language model. It's trained on references. But a human has an intuition and intellect to drive references into a point that is most important. There is knowledge, and then there is intuition, and intuition is contextual, right? And so knowledge alone is not enough unless you have a perception, I guess, in layman's terms, a gut feel, right? I just know that it's something there. So human in the middle is exponentially more important than AI alone. But clinicians and physical therapists right now, we found that it's a helpful tool, but currently it's just a tool. It's just a way for us to add efficiency into a traditional workflow. AI of the future is going to be more than a tool. It's going to be a guide, an aid. And that I'm really optimistic about, because I think once you add AI into a traditional clinical workflow of a physical therapist, then patient management becomes so much more exciting and so much more optimized towards the patient themselves. Our outcomes become better because now we're not guessing, we're not anticipating, and we're also liberating knowledge base from n equals 1, from my expert opinion, right, which is the lowest point of expertise, to n equals 8 billion, because you are using a clinician's intuition with a reference point of 8 billion reference points before that. So like AI in 2025 potentially is still very like that. This is your basement level AI. But AI in the future, in a physical therapy sense, is AI as your loyal companion that helps you do what you do better. So it's and there's boundless examples of that already, but really optimistic about the future of what it holds for us.
Sure, sure. I love that you separated into what it means for us now and what it can mean for us in the future. Just going back to what it means for us now and how, as clinicians using AI today in the physical therapy world, how that impacts them, right? So as you mentioned, there's these AI scribing tools that essentially, the thing that most therapists and most clinicians are going to kind of quib about the most is that documentation time, right? So essentially they're assisting with that bigger problem that we imagine ourselves having at the moment, which is that documentation. So in that sense, is it something that we are still not using to its full potential as we could today? Because, yeah, we may be just using it as a scribe tool or a documentation sort of dictation tool. Or are there tools out there today that could help us even further beyond just that? I understand, as you mentioned, the future of it being a companion and kind of that friend that we have with us wherever we go to help us be that, use that human plus that AI tool at that point. But in today's world, are we optimizing what we can be doing with AI with what we currently have? Are we optimizing that within the clinics so far?
Yeah, so right now, I think I guess, doing even a reference point of what is the number of facilities, or what is the number of practitioners that are using this scribe feature of AI in a clinical setting. And it probably still is fractional. I know there's companies that are offering it as one of their feature package for their EMR platforms. But it still hasn't proliferated or penetrated the market to the point where it's part of the accepted norm for a clinician. And I hope in the future it will be. There are definitely tools that allow this scribe feature to also become a guide feature. So once it's scrubbing the ambient data and the language data from the clinical encounter, it actually provides suggestions. And these suggestions you as a clinician can choose to follow, or you can choose to ignore. But I think what language is a way of documenting data. And so even when you and I are communicating, we are transferring data to each other. You're transferring your linguistic data and I'm transferring mine. But that inquiry, that reference point of this data, the attrition is like 95%. So only 5% of this data gets retained, 95% goes into ether. AI that is listening has a capacity of capturing that other 95% and providing it to you as a helpful suggestion. And so you already have companies like Abridge and Walters Kruger that are providing this as a clinical tool for others. And ideally, I think physical therapy community will also embrace these tools on a daily setting, because then think of how helpful it would be that if you are potentially missing a fact from an individual giving you their natural history, but is also mentioning that there's a higher level of catastrophization that you can detect through this ambient feature that you naturally wouldn't, because you are so focused on your next step, right? So yeah, that is like, there's available resources, but I think even the resources we have can still be optimized to serve greater purpose.
Sure. Yes. The first thing comes to my mind as a physical therapist in the clinic, right? A lot of this is even knowing how to use this tool. So going back to how you mentioned, the educating that user on, yes, we have this technology, we have this scribe that, your EMR is embedded with and is going to, provide for you, but how do you use it and why, and what does it mean in your daily current workflows, right? So I think back to just in my practice that, one-on-one with a patient, if I am having this discussion and I want this tool to help me build my documentation right there and then, I do have to voice out my objective findings. I do have to voice out the assessment and the education that I'm providing to this patient, probably in a little bit more depth and a little bit more you know, interaction with this patient than I would have if I were just typing things out directly into my EMR templating, right? So there's this bit of having, I think, for clinicians to have to understand how their clinical encounter may slightly change a little bit with the adoption of this tool, or with the the availability of this tool. But then to adopt it requires you to be able to actually do these subtle changes that is going to actually be then useful for you down the line. So I think, as you mentioned, I think the current atmosphere of using such tools is more of a just not understanding how to or where it fits into our current workflows. But hopefully, as people get more and more exposed and more educated on it, it becomes more of again, another toolbox, and that it just kind of comes automatically to us, hopefully, because it is a time saver at the end of the day. It is something that, as you mentioned, is not just a time saver, but also can help you really build your clinical, assessments and clinical encounters with your patients and make them much more effective. Right?
Yeah, if you think about it, just the value for you, even clinical encounter, as the reference you were saying, that you have to voice out your objective findings, you have to voice out your observation. I think that actually opens a much greater level of transparency between you and your patient. Like you take away the mystery. You open up this communication that if you find an objective finding, or if you find something of potential concern, there's no longer a black box and a wall between you and the patient. It's out there, it's open, and it opens a communication portal. So I think that in a way, if we frame it as a value add to your clinical encounter, this medical scribe feature, or the clinical scribe feature of your note taking, is a way for you to open up communication between you and the patient. It's actually value add to both parties involved, to you as a clinician and to the patient. So yeah, it would be great.
Yeah, I think great point, because that's the next question I was going to ask you, is that having this ability to have this conversation out loud in front of your patient, to be able to, obviously at the end of the day, include it in your documentation. What that does, as you mentioned, building that communication bridge between you and the patient. But what it does for then buy-in for this patient, I believe, right? As physical therapists, as providers, we talk a lot about getting that patient to buy into treatment, to come back to see us, to give their hand in making sure that they are also going to be part of this whole recovery process. It's not just a clinician to patient sort of input. I think that buy-in is what will really change the trajectory of where your patient care is going to go, and where your own, as a clinician, where your own burnout or where your own input might kind of change, because now you have this buy-in with this patient, you have this relationship building that you've done, which happens organically within our clinician PT patient kind of workspace. But at the same time, I think it just elevates that relationship even further, which, as you mentioned, can lead to and open up all kinds of opportunities, right, for this patient and as the clinician itself.
Absolutely, absolutely. I think it's only a value add to everyone involved.
So then in that case, robots will not replace the future of physical therapists, correct?
Time will tell, Minal, time will tell.
Yeah.
Personally, looking forward to my robotic overlords in the future. I think that the robots, the interesting analogy is there was a point in time when the cars were coming to the market, right, in the beginning of 20th century. And so people would refuse to get into these horseless carriages because they thought that how can a human control a vehicle that doesn't have another ambient being attached to it. And so for a long time, they were putting these fake horses' heads on these cars so that people will get more comfortable getting into it. And then ultimately, there's the adoption curve that people got more comfortable and the cars became mainstay. I think robotics and extension, again, it all goes down to a natural extension of human ability. So robots will definitely not take over humanity from how we've seen it in Terminator series or in the science fiction. But robots have already taken over everything we do. We get into smart cars, operate our smartphones, and look into our smart television sets. So it's, in a way, the first cyborg, the first human to actually use who has become a cyborg, who has extended their natural ability, was a person who picked up a rock to crush a walnut, right? Because your fist can't crush a walnut, but the rock can. So you extended your ability by taking a tool and extending your strength. Robotics is the same, right? There's some things that technology does better than we do. It's stronger, it's faster, it computes more data points. There's some things that we do better than technology. We have an entire plethora of chemistry and electricity running through us that helps us be what we are. And so technology can't do that. I think there's a biggest problem if you look in technology is human gait. Robots can't walk like humans, and it's taken technologists almost half a century to not even come close to what we are, because there's so much complexity into how we walk, and technology can't reproduce that. That same goes for dexterity. A robot cannot have the same level of tactile dexterity that a human can, just because of the endless amount of complexity that is involved in how we touch and feel things. So robots will not take over the world, but then why should they, right? The robots will do their things and we will do our things. And I think when you combine it together, we only look into a much more prolific, much brighter future for both of us. So.
Yeah. That symbiotic relationship between us and that technology that is useful for all parties, right, at the end of the day. So, if we talk about a traditional outpatient physical therapy clinic today, what does it look like in 20 years? What does it look like in 20, 25 years? Where's the meeting of that technology plus tradition?
Yeah, I mean, it's a wonderful question. And what does it look like in 20 years? I would even go to say, what does it look like in 5 years? I think the very optimistic forecast into 5 years is that you're going to have clinics that will embrace technology on every level. So you're going to have these, pseudo robots that are observing traditional patient exercise participation. And so we can leverage computer vision as a way of improving granularity of exercise participation. We can create 150 data points that we're tracking an individual doing a simple squat in order to detect whether there's any qualitative or quantitative difference from the time before. And that's the technology that's already there. And then for your documentation is done in a way that improves both your efficiency in documentation, but also improves the likelihood of you being reimbursed for the service, because you no longer have the chance of having an attrition of your services being rendered incomplete or inefficient, so that reimbursement is denied. And then on a larger level, technology will help democratize our clinical skill set so that we can expand our understanding of a human condition better, so that we can actually evolve our processes from where they are now to, in 5 years, actually seeing where this individual who we're seeing in this point of time, what their trajectory looks like. And I think technology can do that, where the same patient that's pursuing your care in an outpatient physical therapy clinic is not seen from a current data point, but seen from a current data point through the trajectory. So that's my optimistic goal. My less optimistic goal is that in 5 years we'll be where we are now, like that's where we are before. And I think hopefully it's a call to action to the stakeholders in an outpatient physical therapy world, where not just embrace technology from a standpoint of understanding, but bring it into your practice, bring it into your clinic, allow clinicians time to experiment with technology. Again, teaching the teacher, right? Bringing technology into your brick and mortar site, and let clinicians take over. Physical therapists are genuinely highly intelligent professionals. Physical therapists will do wonderful things with technology if it is available to them, and they will innovate and they will progress it. We need more clinicians, we need more physical therapists, not just trying to leave clinical setting because like for the greener non-clinical jobs, but we actually need clinicians to continue to embrace clinical care and integrate technology into it so that they become clinical innovators. And hopefully that's my less optimistic but more realistic goal. In 5 years, every clinician will be a technology-armed clinician that will just continue to innovate and progress our profession.
Yeah, absolutely. I think it's key that, as you mentioned, that in the next 5 years, if anything, were to change in this very traditional settings, it is that each clinician part of that organization is more aware, more open to, and has more tools, digital tools available to them, technological tools available to them to bring back into that clinic. And it can be, in my opinion, it can be as small as, if we want to consider it small, it can be as small as something like virtual front office, or as large as, a fully automated check-in kiosk process, along with, the computer vision, as you mentioned, and when they finally go in to see the therapist, movements are taken by this computer vision technology and then fed to the therapist, and the therapist now has the ability to, clinically assess exactly what's going on with these actual numbers now, instead of just their visuals, right? It can be such a large spectrum of how it can be incorporated into the organizations and into clinics. And sometimes I think, I don't know if you feel this way, but sometimes I think we put a lot of pressure on ourselves to be somewhere and to do something, unique in a clinic, or to offer something very out of the box. But at the same time, it need not be that way. It really could be just looking at all your processes at the moment, and from the front office end to the back office end and everything in between, and seeing where some inefficiencies may lie, and maybe start interjecting some of those opportunities into those inefficiencies and seeing how you can improve. And there are, as you mentioned, a few companies out there that are already doing this, but there are so many opportunities and companies and different tools that are out there now. Again, it's just a matter of us being educated and aware about them, and bringing them in. And so I guess that's the next question to you. Whose responsibility really is that to be educated on that? Is it each individual staff level therapist? Is it, your owner of that outpatient PT? Is it in an enterprise level? Is there a whole other, sort of section of that enterprise system that, is feeding this clinical innovation? Given the breadth of sort of types of companies that we do have out there, in terms of a small one therapist, clinic, to multi-level, multi-segment clinics, where's the responsibility? Who has the responsibility to be doing these things?
Yeah, that's an important question to ask, and I think that there's a simple dichotomy of exploration, exploitation, right? So I think the exploration phase is everybody's responsibility, but truthfully, it is these smaller practices. It is your one therapist practice or 1 to 3 site practice that have the greatest opportunity to change our profession favorably, because they're the ones that have the most to gain from adding technology into their practice. They're the ones that have the most to gain because they're being liaisons and they're being providers to their general communities. They're part of their community. Like the physical therapists who have niche practices, who have small sites, who are not part of these large organizations, are the ones that are fully ingrained into their neighborhoods and communities and sports. And so for them, they have the most to gain from exploring these technologies, but then ultimately, when they're comfortable with them, from exploiting them to be even a bigger part of their community, being a bigger part of their uh, service provision. So it is everyone. It is definitely clinicians that have to be comfortable with exposure to technology, to get out of that siloed approach of I've done this long enough, so I know what I'm doing, and actually be open to explore. Maybe there's something better. Or maybe there's something that can help me add value to what I do. It is also for the practice owners to look into these systems and technologies and really question not just how it will improve my ROI, which is incredibly important. It is incredibly important to know that. But it's also how would this improve to the quality of life of my employees if I add this technology into my setting? Will it be a value add to my employees, to my physical therapists that are providing care? Would it help them do what they do better? And it is these like smaller practices that probably can have the biggest impact on our profession in the future in the next 5 years. So I really hope that if they are listening, that they will explore what's out there and they will have a very clear set of check boxes, or I guess checklists to what it is that they're looking for. Because I think that once they have clarity to what they're looking for, they'll have greater clarity of adding these technologies into their daily workflow.
Sure. I want to diverge a little bit just based on what you just mentioned here, Alex, where, these smaller practices, single therapist, 1 to 2 therapist organizations being part of the community as much as they are. And that's such a true observation because they are either very niche and have, embedded themselves into the community where they're known for exactly what it is that they offer and people are willing and wanting to go in and see them, or they're not niche, but they have established themselves in the community as somebody who, can assist with any kind of musculoskeletal care, etc. But that part of being embedded within the community, I think speaks a lot to this whole other side of, our physical therapy profession that is really still, I think, struggling to be the primary face of care, right? There's primary care physicians, and there's also physical therapists, and there's so much to be said about where physical therapy as a profession can be that primary stepping stone for a lot of these, issues that patients might be looking to get care for. And so, does that start at the grassroots level? For us, is it these smaller organizations that are embedded within the community? Is that where we are going to start seeing much more of this understanding as for the general population that we are the primary care providers in many cases for musculoskeletal care? So I like that you mentioned that in terms of technology, but also what does it do for our profession in the long run for embedding ourselves as the primary providers?
Yeah, I think you're absolutely right, Manal. We have been primary care providers for a long time. We just never labeled it as such. But there's a couple of examples that you can look into. And I think Julie Fritz has done a number of wonderful studies in the last 2 decades that has shown that a point of contact, initial point of contact for musculoskeletal complaint is a huge predictor for downstream healthcare utilization, which means that if somebody sees physical therapist for a musculoskeletal complaint, the likelihood of that individual spending just the money for that specific complaint is exponentially lower than if they go through the traditional model of like the triage of clinicians and experts. The second point of reference is not even about the healthcare economics, but the clinical outcomes. Physical therapists as a primary care musculoskeletal provider result in better downstream clinical outcomes. You have people that have lower rates of pain and disability in 3 months and 6 months and a year. You ultimately see physical therapy first, no disability after a year. Traditional model continuing to pursue medical care after a year, which is like this is information that has been run through large hospital systems. But I think here the caveat is, even though we are primary care providers, we need to be recognized as such by the payers. And the payers need to provide financial incentives for physical therapists to continue to embrace this model, because it's important for the payers to provide equity to physical therapists for the service that they render. And right now, it's not present, right? We're still collecting on a fee-for-service model that does not reward you for providing high-level expertise. It pretty much rewards you the same whether you're high-level or low-level expert, because it's the same CPT code. But if this changes, and if a lot of payers will start endorsing physical therapists as a primary care musculoskeletal providers, this will all change. I think another little important caveat is there's primary care physicians that have been on the forefront. They've been dealing with this for also decades, and they have similar problems to what we have. They have similar burnout problems. They have similar frustrations. I think there's an opportunity to align between physical therapists and primary care physicians in what we can do to the general public. We can cut costs, we can improve outcomes, and we can really help U.S. healthcare system move into the next stage. So hopefully, right, there's going to be change, and hopefully there's going to be a payer recognition of it through a multitude of high-level reimbursement from this.
Yeah, sure. Of course, the incentive, to be that primary care musculoskeletal provider is a huge caveat. It's one of those things, as you mentioned, if it's a CPT code that's going to be billed out for, in one place, and then versus another place, and it's the same value that you're getting for it, then where's the incentive? And so, I think the drive surely has to come from, the PT space, the physical therapy space in general, that we label ourselves as, for sure, these providers are these, clinicians that can provide this type of care and be the first point of contact and provide good level care to not only have, appropriate outcomes, but then also to improve the efficiency as well in terms of cost. But at the same time, then the places where we do get reimbursed from, and the places where we do get the incentives from, have to start seeing that same value in us as well. And I think most traditional models these days, it's hard to move yourself out of those traditional models, but there are certainly, all different kinds of models that are now being exposed. The primary care physician plus PT model that we've seen quite a bit of a trend in now, where, as you mentioned, they're the force, they're the team that then triages and makes sure that musculoskeletal complaint that comes in is taken care of to the best of its ability. And those are the kinds of innovations. I think those are the kinds of sort of out of the box thinking, out of the box sort of opportunities that people are looking for coming out of school these days. Younger generation PTs, I think, have a little bit more probably of that oomph and that mindset to be able to look for something new and efficient, because obviously they went into PT school for what they enjoy to do, which is see patients and treat patients and make them feel better. But of course, at the end of the day, the traditional model no longer is a appropriate model for them, right? So
Yeah.
At the end of the day, hopefully the traditional model isn't necessarily, it's not going to be extinct by any means, but it's a change. It's a reimagined model for other places in physical therapy as well, right?
I think it's so important to separate physical therapy as a discipline from a physical therapist as a practitioner. And we, for so long in the United States, have classified both as one and the same. So we refer to physical therapy. We don't refer to a physical therapist. And I think difference being is that physical therapy as a discipline, it has a significant history and significant empirical grassroots evidence behind it. But then physical therapist as a practitioner has to embrace this primary care model as a point of autonomy. We have to take ownership of our professionalism. And you are absolutely right. The new graduates may come out of school having a high level of confidence and high level of need for autonomy, but then they're slowly indoctrinated into this lethargic model of care where you're just an extension of a larger system. You're just here to see your exponential number of patients. You're nothing more than a label on a door, and so you're interchangeable. If you leave, somebody else will come in and take your spot. And if that's the case, if you're working for an organization that sees you as one of many, right? You have 900 sites and you're just one of like the mass. Then you're not advocating for yourself and you're not advocating for your profession. But you as a physical therapist have to take ownership and honor and responsibility in your professional development. You have to take ownership into being the best clinician you can be for yourself and for your patients. And you have to take ownership in the driving your practice to something that it needs to be, which is a liaison to patient care, a liaison to your patients.
Sure, sure. I think going back to what we mentioned previously regarding whose responsibility really is it to start, to incorporate technology, incorporate the new up and coming, digital health opportunities that are out there now for physical therapists. And this ties right in. It's the individual's responsibility at the end of the day, because who's to say? I have a great example of this. I was working with a clinic just a couple of weeks ago, and it's a gentleman who has been in practice for, I think, about 30 years now. Physical therapist himself, been in practice for 30 years, and he's just employed a brand new graduate of PT who, interned with him at some point, but then, is now is with him as an employee. And, the raving reviews he has of her skills and her ability to think outside of the box and provide, input in places where he never even thought of could be a possibility. But at the same time, listening to her reviews on, well, he's given me so much information on expertise on, clinical care or thinking also outside of the box and how to help his patient, improve in their journey of their care. So the combination of the two, it was just really heartwarming to hear, how both of them had such good things to say about both of their experiences and where they're coming from and what they can put into now this clinic. That's just the two of them in this clinic, and what they're excited for their future of their patients as well. So I think it's it's something that the newer generation that's coming out from PT school can certainly bring into a lot of these traditional models to help bring them, along. And sure, they're also, and I remember as a PT student when I first came out, you're concentrated on how to treat your patient and what to do best, and making sure that you don't hurt them. But at the same time, being able to also have that input in your workplace is a very important aspect as well.
Yeah, that's a growth mindset, right? And I think if you can find a way, even if you have been in practice for 30 years, to just really become less rigid and more growth oriented, and just accept that multitude of different ways of seeing this world, and the way that the new grads that are coming out of school are actually bringing this new energy, new life into your practice, a new way of looking at things, and not as right or wrong, but potentially sometimes different, but good different. And that's, again, a value add, because now you've just extended your mindset, you've extended your acceptance of this worldview, and you've grown. And this growth mindset is so important to all of us as professionals, but as humans, that every day is an opportunity to learn. And so when you're adding new blood to your practice, that's your opportunity to learn. Also give, obviously, something in return, but then learn and embrace that. So yeah, it's great.
Yeah, I think, for the most part, the human interaction of the PT space, when a patient walks into your clinic and you are going to be treating them, and the human interaction that happens, the relationship that is being built, how it is today, that itself is always going to be the backbone of a physical therapy industry, isn't it? We are humans first. We can connect to those patients in such a way that makes them want to come back, and makes them feel better, and makes them want to have, you know, trust us in their journey of their care. So I think for the most part, even the traditional models, we need to understand, and keep trust that fact that that human component is never going to leave us. It's one of those things that will only be enhanced further, with other additional tools that we might have to be able to employ now with with other technologies and things like that. But that human component is never going to leave, and that's ultimately what's going to make your organization successful, isn't it? It's that human component, and then everything else is just an additional tool to help make you as efficient as possible with that.
I think if you look into, I don't know if you remember those old books, the Find Waldo books.
Yeah.
Like that, like a human component is Waldo. Like that's what we do best. And I think what technology does is it takes all of the other noise away from it. Like it just lets you center on Waldo, and everything else goes away. We are patient-centeredness and patient-centric care is the foundation of physical therapy. And it will never go away because that's who we are. But what technology does is it takes away from all the other minutiae of things that really burden us, and again take away our energy, so that we are no longer able to focus on the patient as well. On the contrary, I think adding technology into a clinical workflow allows you to be more human-centric, allows you to be more patient-centric. So I hope that this will resonate with individuals.
All right, Alex. So speaking of all the technology and the opportunities and tools that are out there in the space currently, I want to focus on one tool, which obviously, if for the most part, in every outpatient ortho clinic that you're going to see out there, is going to have within their system is an EMR, right, or an EHR, for making sure that they can do the things that they need to do in their practice. And so there's SPRY out there that has the technology built within its system to be able to help certain aspects of this outpatient ortho clinic be as efficient as possible. And just for our viewers, with SPRY, it's a EMR digital, EMR that is going to help, and billing practice that's going to help your practice from the scheduling side all the way to the billing side and everything in between, to help create efficiency within your system. So given that there are tools like this out there, Alex, currently available to users, what is your take on having such organizations employ these kinds of tools? And of course, they may be not necessarily used to the actual tool itself and be able to know exactly how to use it and what it's going to do for you, but to be open to it. What do you think it means for organizations out there that are willing to take on tools like SPRY into their system?
I think so. I will come from a marginally biased standpoint, and I think I've been exposed to so many different EMR systems, and I have not seen a better one than SPRY. And I'm coming from a standpoint of the ability for SPRY to work with the industry and to actually try to improve and enhance the industry, instead of fitting this as a tool that is discriminate of industry and just wants the tool to be used. I've also seen SPRY add an exponential amount of agility into their product. It's evolving together with the industry, and so that evolution is done through listening and through providing insight into the practitioners that are using the tools, so that the practitioners are the ones that are driving SPRY product forward. And I think that is really unique, because it's not the product that is being forced on practitioners, but practitioners that are shaping the product to be what it is. So I think, again, that this exploration, I think all it takes is one step to get to experiment with SPRY in your system and to see whether it provides any value. And that exploration can lead to a much greater amount of improvement and enhancement into your product. So I am both a fan, but also see that these instruments need to be present in the clinic. It no longer is a luxury to have a smart operating system in your clinic. Now it's a necessity if you want your clinic to be viable and efficient for the next decade and beyond. So I really hope that people listening to this will at least go on the SPRY website and be able to check it out and see what it can offer them.
Sure, absolutely. It's no longer, I like that you said it's no longer, an option. It's a necessity now. And actually, the necessity is you don't have to be, settle for a legacy system. You don't have to settle for X, Y, and Z. You can actually demand for more. And SPRY is one of those systems where, the users, when they are on it, they are demanding more and they are being, listened to. And obviously that is then improving on the ground for them, on the daily, in person, in action, every single day. Yeah. All right. So great conversation with you today, Alex. We covered lots and lots of angles of physical therapy, from the digital health space to, what it means in our profession itself outside of the digital technology framework for physical therapy. So really appreciate your time. Thank you for all your input and your knowledge. Certainly, great to hear from the rest of our listeners when this podcast is out and our listeners are listening. What is it that they are considering to be important topics for us to address? It's not just a matter of addressing one part of the space, right? I think you agree with me that this is about a general overview of what healthcare and physical therapy and where they meet and how we can sort of have those important discussions with our listeners as well. So if there's anything else you'd like to add here.
No, thank you for the wonderful conversation. I really enjoyed this. The hour has gone by very quickly, but I'm looking forward to the next multiple conversations and seeing the ground that we can cover.
Perfect. Thank you very much.